Now, in the last several years, we've actually gotten much better at that, and the pregnancy rates seem to be comparable to embryo freezing and comparable to our fresh IVF cycles. So it's a very exciting area. I think more so for patients who are undergoing medical treatment that will render them infertile, so patients who are having chemotherapy. And many of these are young women that don't have the option to preserve embryos, that are single, and so egg freezing is a very viable option for them at this point. And we still, our society right now looks at egg freezing as experimental, which it is because it's still fairly new and we don't have a lot of data to offer patients as far as the long-term outcomes. But I think we're hopeful that as we accumulate more and more data that it'll really become a mainstream procedure for patients.
And with something like, as you mentioned, cancer, for example, in a woman, would this, as looking down the years, do you think it's going to be more available to people who are really worried about maybe not being able to conceive at a certain time to go through this process?
I think so. I think, you know, right now it's, when I speak to patients about it, I explain to them that it's available to anyone as long as you understand and that you have you have informed consent. And so if you understand that it's experimental and that we're not promising you preservation of your fertility, but we're offering you an option, then it's available to all women. And so we see many women coming in who just have not met the right person yet, or you know, have a career that they're pursuing and want to be smart about preserving their options. And so I usually tell women, don't use this technique as a method to further delay, but if a delay is imminent and there's no way around it, then it's a good option.
Oh. Now, what is really unique about the Greenwich Fertility Center? And you certainly know what that would be in terms of patient care and treatment. When somebody comes in to you, as you say, a couple, I imagine usually, but maybe female comes in, take us through the procedure. That may just allay any kind of fears out there that a couple or a person may have.
So I think one of the big things is number one, a lot of women or couples don't feel like this is a diagnosis that you can talk about. People feel somewhat ashamed of this or embarrassed to say that they're receiving treatment for infertility. And the reality is many couples require assistance to be able to conceive. And so the field has progressed in a way that you have sort of several dominant centers that have outstanding pregnancy rates. We spoke about NYU, there are several others, but these are very big centers that patients often feel overwhelmed once you get in the door and you feel that this is a process that you're going through. And so what's really, I think, amazing, and even for me, just I spend half of my time at NYU and half of my time here, is the intimacy of the environment that we take care of patients in. And so from the moment they get there, it's a small enough office that you'll always know the face that you encounter. So the person who's at the front desk, the billers, everybody is very involved in your care. And we really try to do a very personal one-on-one encounter from the start to the finish of your treatment. And I think, as we talked about earlier, the ability to be able to now offer the advanced technology like IVF in the laboratory aspect of things at Greenwich Hospital, where for years Greenwich has been known to really just offer excellence in their care, and patient satisfaction is a real tremendous thing that Greenwich prides itself in. And so I think combining those two things where patients now can feel like you're getting that experience of an outstanding world-renowned fertility center, but in a very personal, intimate setting where care is one-to-one. Our nurses really work to sort of hold their hand throughout the process as well. So once they meet the physician and a plan is set, then the nurses really touch base with them, talk to them on the phone. They do one-on-one interviews to teach them how to go through the process. So that's a big component of it, is just understanding, what am I going to do, what does this entail? It's medication, it's injections, and that can be overwhelming. And so while at many centers you might sit in a class of several couples, at Greenwich Fertility Center we do it one-on-one, so you have a private, a nurse giving you a private teaching session, and that patients like that. And they also, instead of coming in and having just many centers work on, once you're into the system and you're monitoring your fertility treatment, you just show up in the morning, and many places call it morning monitoring, and you just sit and wait for the next slot. And that's common practice, and most patients do fine with that. But the way we do it at Greenwich is you have a scheduled appointment time, you have bloods drawn at a specific time, and you see the doctor for an ultrasound at a specific time. So we're just very aware of that women have other priorities in life,
Yeah.
and they need to have a bit of a schedule and also something to expect. And so patients tend to really respond to that as well.
Listening to you, it's amazing. I'm going back probably about 15 years or more, long before this was available here at Greenwich, and doing programs with a hospital and people from Greenwich having to go to New York for IVF when that was
Right.
brand new, more or less. And now to hear all of this of what you're doing now and what the staff is doing is tremendous. How big a staff is it, by the way?
It's a fairly small staff. We have a group of an administrator and our patient support group, which consists of 3 billing assistants, and then we also have a group of nurses. And generally, we have 2 to 3 nurses that are working all the time, and then other nurses that fill in when we have, a need for more. And then 2 main physicians, myself and Dr. Barry Witt, who is the medical director, as you mentioned before, as well as several other NYU physicians who are covering physicians in the case of the need for backup.
What, if any, psychological help is needed or afforded to couples? As you said, sometimes, they've got to overcome the either maybe family or just friends
Right.
who look at it a little bit askance here with something wrong, because it's a very intimate situation. Is there that kind of help that's needed, and do you have that?
There is, and more, I think patients are expressing that they want that, whereas, even just a few years ago, I think patients tried to keep it so private and didn't want to ask for help, and now I think that women are more forthcoming with asking for help. And so, again, at a center like Greenwich Fertility Center, where it is a very small, intimate practice, many of the women, just through our own staff, get a lot of support. And then in addition to that, we work very closely with the integrative medicine services at Greenwich Hospital, who offer acupuncture, yoga, mind-body imagery to really help patients get their body mentally prepared for the process, as well as what we're doing on the medical side of things. And I think that that's been an area that has really blossomed in the last several years, both at Greenwich Fertility and also at NYU. We've really expanded what we call our wellness program, with the idea of that it's a whole process. It's really a holistic approach, trying to have a woman feel prepared and feel supported in going through the process.
The evaluation process, Dr. Fino, when they come in, maybe take us through that. What you ask the people, what they should be ready to tell you, let you know, and then take us through a little bit of the process length, if you will, of how long, hopefully, to a successful conclusion.
So basically, when a couple first comes in, it's a very straightforward medical consultation. I do a careful history and physical exam. In the history, I pay close attention to the woman's menstrual cycle, and if there's been any irregularity, any changes, and then I ask a detailed medical history as well. So sometimes patients are surprised that you really delve into other medical problems and not just fertility or reproduction related things. But really, again, it's a holistic approach, and one area of a problem in the medical field can be related. And so we do a very thorough history, and like I said, the physical exam. And then I always, at my initial consultation, really give patients sort of what to expect in the next series of appointments. And so the next appointment is usually based on the starting of their menstrual cycle. We start with those tests that we talked about. So the patient kind of starts with you in their consultation, and finishing that, we say, okay, you're going to come back with your period. With that period, we'll do a blood test on the second day. At the same time, your partner will come in and do a semen analysis sometime during that first couple of weeks of the cycle. And then usually between days 5 and 12 of the menstrual cycle, we'll do that second test to evaluate the uterine cavity and the fallopian tubes. And after that, you really have a good chunk of your initial workup done. So it's the day 2 blood, the hysterosalpingogram, the semen analysis during that time. And then usually by the time I'm meeting the patient for the hysterosalpingogram, we have all the information collected and we can sort of solidify a next step. And next steps can be anything from a fertility drug to enhance the natural response without using assisted reproductive technology, so something like Clomid. fertility surgeries, depending on what you find on that hysterosalpingogram, if there's an anatomical problem, or moving on to more aggressive treatment like infertility, in vitro fertilization.